Good afternoon, everyone. Let me welcome those of you who has joined us for the first day of this virtual symposium yesterday, and to welcome you who may only have a chance to join us today. Now let me first introduce you to some rules briefly here that we hope to see a number of attendees for today. So all of you are currently muted, but we do have time allocated for the Q&A session. So please feel free to put your questions on the Q&A box at any time, and we will ensure that we have enough time to address all your questions. And then the recording and slides, we always get these questions of whether we can send to you the slides or the presentation. We will also make sure that all the slides and recording will be available in the IAS Plus platform. And we also would like to encourage you. I can see that some of you have started doing this already, to use the chat box to introduce yourself. Let us know where you are coming from, and we always love to see like interactive chats in that chat box. And before we move on, I also would like to thank our donors, Gilead Sciences and Viv Healthcare. And for today's agenda, we will be talking about chemsex and virtual solutions. And we will start with a presentation on takeaways from the 2024 Asia Pacific Chemsex Symposium. And that will be followed by a panel discussion on innovative integrated chemsex harm reduction services in Southeast Asia. We will have Q&A session after the panel discussion, and then we'll have a short break and to come back with the presentation on digital health and virtual interventions for HIV in Southeast Asia. And we will hear experiences from two countries, Thailand and the Philippines, on how they use virtual solutions for HIV and sexual health services. And now let me introduce you to our first speaker, Dr. Akarin Hiransutikun. Dr. Akarin is an assistant professor of community medicine at the Department of Preventive and Social Medicine, Faculty of Medicine, Chulalongkorn University here in Bangkok, Thailand. Dr. Akarin will be presenting on takeaways from the 2024 Asia Pacific Chemsex Symposium, or APCS 2024, which was held in Bangkok in November last year. Karin, the floor is now yours.
Thank you very much for the kind introduction, Dr. Nitya. And I'm just going to share my slide here, and I believe that it should pop in, hopefully, on everyone's screen right now. If not, please let me know. Okay. Thank you again for the invitation, and it is a great pleasure for me today to talk to everyone about the key takeaways from the 2024 Asia Pacific Chemsex Symposium, which has a theme in italic here: pleasures, policies, and possibilities. I think it is most appropriate to start off by telling everyone, for those who did not know about the Asia Pacific Chemsex Symposium, what is it? So for Asia Pacific Chemsex Symposium, or APCS for short, it was first held in 2019 in Taiwan in response to the rising in the prevalence, also the visibility of chemsex in our region. It has been a critical platform connecting all people, multi-stakeholders from communities member, healthcare providers, NGOs, researchers, policymakers, donors, you name it, across Asia Pacific. And also, it has been a culturally sensitive, safe, and multidisciplinary space for sharing knowledge, sharing experience, and of course, for collaboration. Now, for today's presentation, I will be talking briefly only about the last year edition or the APCS 2024, which was the 6th meeting held here in Bangkok, Thailand. And it was the first meeting to be held outside of Taiwan. There were over 300 participants from 27 countries, and I should know that there are people from outside of Asia Pacific region as well. And the theme, as I mentioned earlier, is pleasures, policies, and possibilities. Now, focusing on the theme here, what are those? For pleasures, the key message here perhaps is to communicate, or rather, I should say, to emphasize the importance of shifting from the risk-based approach, which I should say, unfortunately, more often than not, that's the way that we have been taught to do in several years, to pleasure-based approach. In another sense is to, have a more balanced humane lens, not only just focus on, for instance, the risk of chemsex is HIV, STI, mental health, etc. Not just focusing on that, but really understand how how we think, how humans decide to use substance. So understanding why people engage in chemsex as well, not just focusing on the risk. For policies, it is to emphasize that we need other people beyond the healthcare or the science world as well. We need to address legal, structural, and stigma barriers, and also engage policymakers, legal experts, and legal enforcement. Last but not least, possibilities beyond abstinence. That's it. So we should not forget to explore new service models, new harm reduction models. And these are the key themes of last year's symposium. And I will base my talk here exploring each of the three themes here. Start off first with pleasures. As I mentioned earlier, so I think very briefly is the concept of shifting from the risk-based approach to a more positive message or pleasure-based approach. And from, I think some of the literature that we may have seen before for here, using methamphetamine as the representative of the substance use or the chemsex, many of the literature when talking about methamphetamine, there are two common themes here. The first thing is that methamphetamine is associated with sexual disinhibition, which consequently lead to risky behavior or health outcome. The second theme that a lot of literatures are focusing on is that methamphetamine often attracts men already inclined towards these risks. In another word, they are going to engage in these quote unquote risky behavior anyway, regardless of the use of methamphetamine. Again, these are kind of like review of a lot of literatures in the past, and these are what researchers usually talk about. So as you see here, we talk about risk. And from the meeting is conclusion is that this might not be the best way to go. We should also focusing on like the positive side of things or the pleasure side of things, or perhaps the underlying reason of why people start or maintain their use of chemsex as well. So this is a great review that was presented, cited during the presentation as well. It's from AppCom. So they explore deeper than just risk. For this case, it's motivation. And for this review, they provide the example of those said motivations as well, as you can see it here. For instance, enhanced and extended sexual gratification and pleasure, pride, empowerment, beauty and social power, or even social lubricant, and community identity and culture, etc. Again, seeking deeper, delve deeper into the reason, not just superficially on the risk. And some of the example of those services, those ideas is from the pleasure principles. I really encourage anyone who's interested to look up more into it. This is a guide to support people or the organizations to first step, starting the journey towards a sex positive, pleasure-based approach to sexual health. And there are some kind of the examples here. You can see the wording. I really like it. Love yourself, embrace learning, talk sexy, be flexible, think universal, rights first. Overall, the theme of being positive. So this is the first thing. Pleasures for the theme of last year's symposium, shifting risk-based to pleasure-based approach. Moving on to the second one, policies. For policies here, I use this information, you need to give a shout out to Dr. Stephen Hu from Taipei City Hospital in Taiwan. If my understanding is, if my memory serves me right, he sent out questionnaires to his colleagues across 12 countries to explore the policy, the legal context of substance use. And across here, you can see 12 countries, all in our region of Asia Pacific, from the furthest left, Hong Kong, Indonesia, Japan, to the furthest right to Vietnam. The key message here for you to see is that there are diversity in policy and legal context. For instance, the first question is, do healthcare providers have a legal obligation to report their clients' use of illicit substance? You can see here that in Japan, in South Korea, and in Singapore, they have that legal obligation. For question 2, 3, and 4, you're going to see a lot of red X's, and those are focusing on whether or not those countries have interventions other than sending the people who use substance to jail. You can see a lot of X's here, including us, Thailand as well. Or the last two questions about the investment from the government, whether it's central or local or regional, in harm reduction policies. You can see a lot of red X's there as well. This is another information in a similar concept of diversity from Gloria Lay, who's from the International Drug Policy Consortium. But besides just the diversity, as you can see here, laid very beautifully in the map, is overall, these are the administrative punishment that you can see that it happens, I'm going to say almost everywhere in our region, just like the number of things are going to vary, but it is still there in our region. And last but not least, in terms of policies, the emphasis in this terminology, decriminalization. Decriminalization. It has been integrated into the UN Special Rapporteur on the Right to Health 2024, focusing on drug use, harm reduction, and the right to health. And the recommendation from this Special Rapporteur is that to decriminalize the use, possession, purchase, and cultivation of drugs for personal use, and move toward alternative regulatory approach for what? For putting the protection of people's health and other human rights front and center. So I'm going to emphasize that again, decriminalization. And I'm going to end this session, this second theme with this quote: decriminalization of substance use and possession for use needs tangible and concerted actions from communities, researchers, providers, legal experts, and policymakers. So as you can see here, multiple stakeholders, multiple groups of people need to work together. Last but not least, the last theme of last year's conference, possibilities beyond abstinence. So during this conference, there were two kits that was presented. The first one is this one, developed by the ASHM, the Australian Society for HIV, Viral Hepatitis, and Sexual Health Medicine, on behalf of the UNAIDS and the UNODC. Chemsex toolkit for clinical service providers in the Asia Pacific region. Now, in this toolkit, and I highly encourage again for anyone who is ready to look through it, because a lot of detail in there. 5 key chapters from getting started for us providers, just to understand chemsex. And you can see the small bullet here, focusing on the positive side of things, the pleasure thing as well, the motivations of chemsex. The second chapter moved towards like how to set up that harm reduction services, and they provide guides and tools, case studies, and also very importantly, chemsex training modules. A very nice read. The second toolkit that was presented in this conference was the chemsex interventions for HIV prevention in Vietnam. It was developed specifically for community outreach workers, and it was a collaborative effort between the Vietnam Administrative of HIV/AIDS Control, Ho Chi Minh City University, the communities, UNAIDS, and the UNODC. The focuses on this particular toolkit was on HIV/STI prevention, mental health, and drug use addiction. And these are kind of the outlines of this particular two case that you can see here, starting off with the overview for all of us to get more understanding of that until the last one of harm reduction interventions. And besides the two kits that were presented in last year's conference, there were also experience sharing as well. So I pick up some of the examples here. These are from Vietnam. The first one from the Lighthouse Social Enterprise, communicating to the attendees of support needs for people using chemsex. They address physical health, mental health, social support, and recovery behavioral management. For another group in Vietnam as well, the chemsex intervention package, focusing on improving physical health, mental health, and sexual health. From us in Thailand, we use the example of the data from our study called the Climax study. We found 4 key components in establishing harm reduction services, which are substance use literacy, mental health counseling, sexual health services, and legal support. Last but not least, an example from Kyrgyzstan, which showed not only the principles that are needed for the service for people who use new psychoactive substances, such as anonymity, gender equality, but the team also show what we as the providers need to prepare and train ourselves for as well. For instance, mental health support, the knowledge on overdose prevention and care, digital safety, legal literacy, etc. And with the quote as well, chemsex service needs to be community-led, comprehensive, and don't forget the legal right harm reduction, people-centered, and pleasure-based. And I'm going to piggyback on yesterday's panel discussion by Rina Danvik and Sripong a bit on sustainability. That sustainability is still the key for the chemsex service as well. Our effort won't be successful unless they last. That's the saying that I really like. We need to make it sustainable. And before I wrap up, I just wanted to highlight that everything I've shared today can be found on this website, APCS 2024. And you will see that the content that I presented here is just like a very, very small fraction of what was in store at last year's conference. I really encourage everyone to check it out. And I should know that it's completely free and open to all. And lastly, to close up, I would like to let everyone know about the upcoming 7th edition of the APCS 2025. Another great opportunity for anyone interested in this topic to connect, for some to reconnect and to learn more. I firmly believe that abstract submissions are now closed, but the registration is still open. So that's it for me. Thank you very much for listening.
Thank you very much, Akarin, for that wonderful takeaways, and I really think that it's always good to be reminded of how like the 3 Ps that were used as the theme of the conference last year can always be kind of the principles of how we design our services or activities, pleasures, policies, and possibilities. So thank you so much. And now let me move to the next session by welcome our moderator for the panel discussion on innovative integrated chemsex harm reduction services in Southeast Asia. Naomi Fontanos, who is Gender Equality and Sustainability and Sustainable Development Officer at APCOM from Bangkok, Thailand as well. Naomi, please.
Thank you, Nitaya. Welcome to this panel discussion. So for this panel, we have the following speakers. She is a program officer at Lighthouse Social Enterprise Vietnam, Hue An Dean. Hello, Hue An. He is the assistant professor and leads the Courage Lab at the Saw Swee Hock School of Public Health, National University of Singapore, and the National University Health System from Singapore. Rainer Tan. Hi, Rainer.
Hello.
He is the research physician affiliated with the Institute of HIV Research and Innovation, or IHRI, and is a recipient of the Mark Weinberg Fellowship from the International AIDS Society from Thailand, Dr. Jakrapatara Fair Bunruwang. Hi, Fair.
Good morning, everybody.
It's nice to see you all. So I'd like to ask this question to Rainer. What makes harm reduction services in Southeast Asia different from those in Europe or North America or in other Asian countries, for example?
Thanks so much, Naomi. Thank you so much for moderating today. Thank you so much to the organizers. Really happy to be here, and to my fellow panelists as well. So I think this is a great question. I think about what harm reduction is meant to achieve, right? And I think harm reduction is meant to ensure that people stay safe, they stay healthy, they stay well. And meeting people where they're at. And what that also means is, understanding what are we reducing, what harms are we reducing? When we think about chemsex or sexualized drug use, actually, even from Dr. Akarin's presentation, we see that there's so much difference and variation here. In terms of, let's say, if we compare it to chemsex as it is written and published, largely originating from the UK or the US, the drugs alone are different. I think the common drugs that are talked about here include like methamphetamine, GHB, and other maybe party drugs. And these might not be commonly used in other settings where chemsex has been written about, or maybe harm reduction has been promoted. And the ways in which drugs are used are also so different. The context in which that they're used, how we administer drugs, they're also different, and it all makes a difference, right? Because how you administer it maybe puts you at risk or makes you more vulnerable to certain pathogens or certain infections and so on. And that's where the harm reduction work is at. But I think that alone is just the situational event level. When we talk about reducing harm in the context of drug use. But I think we also want to sort of like expand the concept of harm reduction, right? And I think that's where stuff like legal and social support comes up. And this is something that I have learned myself from the Climax study from colleagues at IHRI, where they interviewed participants, they engage with people, and they find that the types of support that people who engage in chemsex need is not just the support and harm reduction for drug use and the drug-related harms, but also the social and legal stuff that comes with it. Just now, Dr. Akarin presented a slide on the different legal aspects of drug use, right? Who is going to report you to the police? Where is it decriminalized? You can see how that varying, just that alone, I think shows you that harm reduction should also focus on that. And that might be very different from places in the so-called West or global North, where maybe it's decriminalized in some places. Even I want to also maybe even be cheeky and say that within Southeast Asia, Singapore is so different from Indonesia, it's so different from Thailand, it's so different from Malaysia. All the laws are also so different, right? And maybe even thinking about how Southeast Asia or Asia can come up with a framework that actually acknowledges that we're all very different, and that we need to also look into all these different things to ensure that harm reduction is effective. And I think I'm going to stop here. I can go on about like the differences, but you can tell that just based on drug supply chains, the drugs, the types of policies, the laws, it really shows that harm reduction is going to be so different here. And one thing I also want to suggest in closing is that, for example, we think about international funding streams, right? And how, let's say, we have funding for HIV-related programs or maybe harm reduction-related programs. The kinds of terminologies used to actually, and the parameters used might actually be informed by more Western or more like a global North settings. So, for example, if we're using terms like MSM or TGW, maybe these terms are not as well used in the community. I don't call someone else an MSM, for example. Or maybe even when it comes to PWID, like people who inject drugs, that's the terminology that's used to describe a key population. But actually, if in the UNAIDS context, for example, do we have a term that describes people who engage in chemsex, even though they are, supposedly a key population as well, as we are recognizing? In fact, some people who engage in chemsex also belong to people who inject drugs. So, there's a lot more complexity there. So, thinking through these things and also thinking how, we can come up with our own definitions and, like maybe in spite of international definitions, how can we also still honor, variations in the region? Sorry, I think that's all for me. Thank you.
Thanks, Rainer. Yeah, thank you for letting us know that harm reduction services in Southeast Asia are quite varied, no? Because they depend on the context of those who are affected by it. So my next question is for either Hui An or for Fair. What makes a chemsex support model truly work for the community? Hui An?
Okay. Thank you, Naomi. That's a really thoughtful question. For me, a campsite support model truly works when it starts from the community. When people feel safe enough to show up as who they are, not as someone being judged or fixed. So in Vietnam, campsite is still very hidden issue. I think maybe in the Southeast Asian also, and many people told us that they use drugs to feel like connected, confident, or to escape loneliness. But after session, they often felt anxious, ashamed, or isolated. So, but when they reach out for help, so most services only focus on HIV testing or PrEP. So there was very little space to talk about like mental health, relationship, or pleasure. So at Lighthouse, we realized that harm reduction alone wasn't enough. We needed to integrate psychosocial support and peer connection into our approach. So that how we built two key components like EPAC group support, like an online group therapy program for men who engage in campsite. So we use SMART recovery tool, cognitive behavioral therapy, some even art-based exercise to help people understand what drives their behavior and find new like coping mechanism or strategies. So over time, the group itself becomes a healing space. People share things they have never said or cannot share anywhere else or with anyone else. I think after the program, like about 70 or 80% reported they improve their mental health and their substance use risk. So it's then that's when we know something is working. Like when people begin to trust themselves, to trust their recovery path again. But we think we also created like another model campsite space, like it a peer-led hybrid model. So it open not only to campsite user but also to their partners and friends. So people come to share experience, talk about like harm reduction, or simply feel less alone. So in 1 year, we operating that implement, we reach more than like uh, um 200 participants, and most of them keep coming back. Some even now it become co-facilitator, and some help us to design harm reduction materials or drug use guideline to using drug safety and support new members to connect with group. So I think moments like that show how empowered spread from one person to another. So in my experience, a campsite support model truly work when it's the peer-led, community-led, integrated, and empathetic. I think peer-led because trust and lived experience open the doors that professional alone cannot, and integrated because harm reduction, HIV care, and mental health must go hand in hand. But last but not least, empathetic because I think every person deserves to be seen beyond their drug use as someone seeking safety, connection, and meaning. So that I believe is what make a model truly work for the community.
Thanks, Anne. Lighthouse is doing great work. Fair, any thoughts on this? Just a minute.
Yeah, I will try to summarize everything as well and chime in on what Juan has beautifully said. From her view, that would be more on the peer-led program. But from my point of view, I think it might be different in terms of being a researcher and providers. I may have to chime in on how we can make the service delivery program be more friendly to the community. I think the answer is similar to what Juan has already demonstrated and said, that the community involvement and peer-led program is also very essential in the bigger scheme of things. So if we talk about public health, where things has to be kind of like, implemented throughout in the policy level, I think peer-led and community-led responses are also very important and needs to be addressed for the harm reduction service to be resonating with the community. There have been several incidents where service delivery programs are not resonating with the service recipients, and the prime example of that would be the key population-led PrEP services in Thailand, where it proves that hospital-based PrEP delivery program or the medicalizations of PrEP program is not resonating with the community at all, and that's why we have to shift away to the community-led or key population-led PrEP program, and that boosts the service recipients' access to PrEP tremendously. And this is the lessons that we learn actually from the implementation research that we conducted in IHRI, which is called Climax as well. One of those being the community involvement in the early stage of the service designs is pivotal. And we are lucky enough to not only identify the communities that are willing to kind of voice their needs, but also become the service providers as well, which makes the harm reductions approaches in Thailand born actually from the community. I have to also acknowledge that this is not the perfect implementation process whatsoever, but theoretically, it is a very good way to approach harm reductions. We have faced a lot of struggles throughout this process. We see that the community in chemsex space in Thailand may not be as strong as HIV community in Thailand, and this is because of social stigma, law enforcement, and other kinds of discriminations that Thailand still has to offer. So we have to also prowl through those nuances and problems that may arise from community being able to voices their needs and involve in the public health lens as well. So I would just leave it at that.
Thank you, Fair. So Fair's intervention reminds us that nothing about us without us. You have to consult the communities you serve, right? But another question for you, Fair. Chemsex response is almost exclusively designed for men who have sex with men, or MSM. Are there successful interventions for trans women or trans men who have sex with men?
Thank you, Naomi. This is, I think, is a very important questions that needs to be asked, especially in our region where trans individuals flourishes. The communities are very strong comparing to the Western side of the world as well. Unfortunately, in Thailand right now, and in the public health lens in Southeast Asia, I don't think we have that nuance or resilience to differentiate between the services for men who have sex with men and trans women as of now. However, we have seen some literatures from several countries that identify the differences between substance uses in trans individuals and in men who have sex with men, and that actually tell us that we need different kind of approaches to tackle this problem as well. So in Thailand, in our context, we have conducted another studies called T-Rex, and T-Rex is actually the explorations and identifying problems of chemsex use within trans and gender diverse populations. So we have actually observed a very different perspective from the participants comparing to men who have sex with men. We see that sex working and element of power plays an important role in substance uses in trans people, especially in trans women in Thailand, which is different from what chemsex has been defined from the UK or in Thailand as well, where it mostly related to sexual pleasure and less about sex working and power. But for trans women, that has become a more prominent aspect of chemsex use in their daily lives. Of course, sexual pleasure is one of the important thing that's influence their uses, but things like sex workers, the legalizations of sex working surrounding the country also plays an important role. And that is why we are conducting another studies called implementation T-Rex or IE-T-Rex, which is to implement the what we learn from TLEX into trans and gender diverse people. And I think if we can, fulfill what is needed for this research to kind of like, convey, we will actually see how we can go about designing the service delivery programs for trans women, at least for Thailand, and that can, lead to a more regional efforts as well. So, yeah.
Sounds good. We look forward to the results of ITREX. Yeah. So our last question, we have 3 minutes left. This is for all of you. How has shifting funding priorities impacted the progress in developing innovative, integrated chemsex harm reduction efforts in Southeast Asia? We don't have enough time, so we have 3 minutes left. Anyone?
Okay, I will go first quite briefly, and then I will hand on the mic to other panelists. So in my point of view, I would like to say that, the impact of the funding cut has been substantial to our research program surrounding, gender diverse people, but also harm reductions as well. The prime example of that would be Climax study. We have talked about Climax all the time because it has been, a pivotal studies in terms of harm reduction approaches among men who have sex with men in Thailand. And we aim to also evaluate the implementation outcomes, for example, penetrations and acceptabilities of service recipients in this new innovative program as well. We failed to do that because of the funding cuts, which has stopped us at the baseline visit of the studies. We still have valuable insights that can be extracted from the study, but the aim of trying to make this, program more acceptable or identifying the facilitators and barriers to this program has been cut short because of the funding cuts. And with that, we have to say that we don't know for sure that this program that we are trying to deliver, truly resonates with the community or not. And that is only one of the impacts that, that we have to face in the face of funding cuts.
Rainer, would you like to chime in? You have 1 minute.
Okay, I'll do my best. I just wanted to say that I think one thing that was involved in also was to maybe think about consensus building, right? And this was also work that was done and funded through, let's say, EPIC, FHI 360. Previously there were some conversations, right, happening across different Southeast Asian countries to think about what that framework looks like. Like IHRI. Lighthouse, were all leaders in thinking through what that was. I think that effort has since kind of slowed down, I would say, because like that was also largely supported by some international funders. And I think I wonder, not having that conversation in the past year, how much of that has really stopped us or slowed us down in terms of achieving that. I think quite substantially. We are back in terms of maybe working in areas that are funded, maybe service provision, but I think that platform to really discuss about these things and like this here, like this platform here also, is one way that I'm learning so much from everyone as well. So, I really do think that it set us back at maybe advocacy level, where we advocate for things and help each other out at the regional level.
Thank you, Rainer. Unfortunately, that's the only time we have. So I think you, Hui An, Rainer, and Fair for joining this panel. At this point, we'd like to ask Nitaya to come back and join us. Nitaya?
Thank you very much, Naomi, Rainer, Fair, and Huyan for this wonderful discussion. I couldn't stop smiling, to see like this new generation of people really talking so sharply about the issue that concerning here. And so can I introduce invite back Dr. Akarin to join us here as well for the Q&A session. And while waiting for Dr. Akarin, I just realized that I forgot to introduce myself. My name is Nitaya Panupak, and I'm the Executive Director of the Institute of HIV Research and Innovation at HRI here in Bangkok, and also the IAS Governing Council representative from the Asia Pacific. So thank you for that. Do we have Akarin join us as well? Okay, wonderful. So we have a few questions posted in the Q&A box, and I feel that yes, because we only have like very short time for the panel discussion. So if we can like start with Huyan, if you would like to address that sustainability issue a bit before we go to the question around party drugs and how like your programs adapt to those types of drugs as well.
Okay. I think that's a really interesting question. I like how we found that most effective approach combine like education pillar, and maybe we are not limit us on one kind of drug. We try to mix and integrate it. A lot of information about oh, I'm sorry, but my internet.
We can still hear you well, Huyan. Oh, maybe. Huyan, can you hear us?
Oh, can you
we
hear
can hear
me?
you well. Yes, we can hear you well.
Oh, okay.
Okay. Yeah, please go ahead.
Okay. So at Lighthouse, our harm reduction are designed to be like substance inclusive, meaning we don't limit our services to any single drug. So our educational like material, online outreach, or counseling on emphasize understanding effects, dosage, and mixing risk across like different types of substance. And we also started update our self-help handbooks and online content to include information on another substance like MDMA or cocaine, how to like stay hydrated, avoid polydrug mixing, and recognize warning sign like overheating or serotonin crash. So in terms of psychosocial intervention, our approach remains the same. We focus on mental health, motivation, and self-regulation rather than on the substance itself. The underlying needs, connection, confident escape are similar whether it is meth or MDMA. So what changes it is, I think maybe is the tone of messages. For example, more emphasis on energy balance, emotional recovery, and consent when using party drugs in social setting. So yes, we are trying to prepare to adapt, and we see this shift in not as a challenge, but as a reminder to keep our harm reduction and health services flexible, evidence-based, and community informed.
Very practical response. Thank you, Huyan. So, Fair and Akarin, would you like to address this question as well before we go to Raina?
Dr. Akarin, do you want to answer this or let me go
No, yeah,
first?
please feel free.
Oh, okay. So for our perspective in Thailand, of course, to identify which kind of substance affects your body is very important as well. We see that substance specific prong or component of the service design that we came up with is actually the most popular or the most attractive component of all harm reduction services. So this means that the community themselves are actually starving to, have this kind of knowledge or informations given to them. And since we have implemented this four-prong harm reduction services, which includes substance-specific prong, sexual health prong, mental health prong, and socio-legal prong, we saw that we see that there are a lot of uncertainties surrounding substance-specific prongs in terms of knowledge and informations, because all of these things that people are doing in the community are not really evidence-based, and we do not have enough evidence to actually tell them what is the evidence-based intervention would be, because as you know already that drug use are still illegal in a lot of countries, and therefore limit the ability for researcher to come up with um substantial knowledge to provide for their clients or patients. So that is one of the barriers that we face in terms of implementations, because we don't know what is the best practice for substance specific prong in each kind of substance. So we have to go along the way in terms of combining what the community have been doing, verified it with the medical informations that we have at hand, and then comes up with the advice or recommendations for them. So there is no specific evidence-based packages that we can use and to propagate in that kind of sense. So that's why substance-specific prong or component, even though is the most important part, we still have to find our ways to kind of come up with the rigid evidence or curriculum that we can propagate to other service providers as well. So that's my response.
Thank you. Raina, would you like to add to this as well?
Well, more on the, I guess, like the difference, I guess, across party drugs and like maybe meth in terms of like chemsex practices. Thanks, Harry, for the question, and thanks everyone for the questions as well. I think one thing that I do think about is this idea of like the status neutral approach to HIV. Like, I just like to think through things from like maybe more systems level, and like I do see definitely there's so much value in looking at how people use drugs differently, different drugs in different contexts, like you've already mentioned, because like I also talked about earlier, the risks are different, right? But I also think that something that Huyan talked about that was also so important is that we don't box people, and we don't kind of like determine what people's pathways are the moment they step in, right? That's already already very a lot of assumption, and I think many people are also figuring out themselves, and so something that comes to mind is like this status neutral approach to like HIV. Like, can we do it similarly for drugs? Like where someone comes in for drug use related issues, like we do have information on the different risks associated with different drugs, but to have a status neutral approach, it means that we have to be very comprehensive in understanding the different biological, social, psychological impacts of drugs, and this we have the evidence from many different parts of science, I guess, to do that. But I think yeah, I would love to see that happen. And maybe one thing that I'm also thinking about as we talk about integration is what are we integrating into? Are we integrating chemsex services into HIV services, or are we integrating other things into chemsex services? Like, what is the entry point, to such services? I think that's something that I think about. Thanks for your question.
Yeah, that was wonderfully explained. Akarin, yeah, please.
Thank you, Dr. Nitya. I hear a splendid response from all the panelists here, and like a lot of idea coming up to my mind, like so many, and I will try to be as concrete as possible. Elaborate a little bit from Dr.'s fair response that I think I would assume that many might have encountered the problem that we have faced when we start to work on this topic. I think we start working on this like perhaps 3 years ago, around that time, and we don't know a lot. And from my personal experience, I struggle quite a lot during the first few months that we start working on this, because it feels like there's not a lot of data. We don't know a whole lot of it. Eventually, I think we find a great solution, and that is basically just to talk to the key persons, and that's basically it. For our study, that would be called a climax phase 1 study. So we start off by accepting the fact that we don't know a lot. And then we start small, we start slow, but hopefully it's stable. We start the first half of things, try to explore things from the people directly associated or involved in this topic, the chemsex, to understand what they really want, what they are facing. We gain those knowledge, and then we try to, summarize to a concrete service, try to establish the service that we hope to address the most thing that people in the community really wants, and that's the climax phase 2 that Dr. Fair has mentioned about the funding cut, which so it's unfortunate we would not be able to really assess the effectiveness of the implementation program. But this is how we get that full-pronged services, because we talk to the community, and that's basically it. Now, I would like to perhaps try to address some of the questions here. I see a lot of questions surrounding mental health issues. And again, this is some of the things that we get from the community, from, to be precise, men who have sex with men who use chemsex, and from their family members telling us that, okay, this is something that we want, this is something that is important to us, and that's why it's in the full-pronged services. But during the services itself, again, we got cut short. The mental health service is very tough. I think it starts off by what you will use as a screening tool. It's gonna varies a lot, depends on where you are. For us, we use what we call EMW2, a tool from Columbia University, a very short tool. We hope it's very concise, very easy to do. So we don't have a lot of problems screening mental health issue. Again, trying to address a lot of questions about mental health. We don't have a lot of problem providing the assessment. Great acceptance, almost 100%. But the problem is on that once we detect some of the kind of like the score, and it's like quite concerning, that we want to explore a little bit more in management terms, or further workup or intervention. Only, in fact, can correct me if I'm wrong, I think like around 20-something% actually agree to go through it. They screen, I'm going to use easy term, they screen positive. Around almost 100% agree to screen, but only around 20% of those who screen positive really want to do something about it. And I think that represents the difficulties on this mental health service, because we can only do so much in terms of educating, providing knowledge to the community, to each site. But for the very difficult or challenging issue, for instance, suicidal idea or a major depression, we still need to refer. And that's going to be a lot of challenges, a lot of obstacles, depending on the healthcare services in your countries, including Thailand. So I will end here.
That's a very important point, and I think because we are talking about the community-led service delivery models here, and I think like many questions are around what can be done at the community level, what actually can be done, and by whom. Will that be any like training, quality assessment, quality improvement activities that will be needed? So I would like to hear more from Huyan and Reno as well, because you are providing services at the community level by community people. So would love to learn from your experience and lessons if you can share. Gwen, would you like to go first? Yeah. Reina, sorry. Yeah, Hoyan.
I have a lot of lesson in my mind right now. So maybe Reina, can you go first?
Okay, I'll go. I'll try. I think one quick thing I was thinking of is it's interesting. So actually, one of the questions asked about sustainable strategies, and I think one of the recent WHO HIV service delivery guidelines was talking about integrating mental health into HIV services. And actually, part of that review found that a lot of and this was for low to middle income countries because it was focusing on whether things are sustainable. And a lot of the integrated mental health services, including alcohol use disorders, were like largely peer-driven or task-shifting focus, right? So communities played a big role in making sure that these things are sustainable. I think that is a big thing. There's not enough studies on chemsex, unfortunately, in that review, because I think we don't have that many studies in this region yet, or LMICs. And one thing I also wanted to point out was that is this sustainable for chemsex? I think the community aspect, it's a very strong part. But I also like the idea and the thoughts around, is it enough, right? Because I think when it comes to a certain level of care, maybe we need a psychiatrist involved, or maybe we need a psychologist involved. And to what extent can we empower people, to actually provide some of these services, or provide like triaging kind of like services, right? I think it's definitely possible. Places like Singapore, where I'm at, like communities don't have that much autonomy, I guess, in terms of structuring health services. Other places like in Thailand, community health workers, or people can be certified, and in collaboration with some of these services. I think that's something that we don't see as much here. Very limited. It's still possible. There are people like from Action for AIDS doing it. But for the greenhouse where I've been at, largely it's about a lot of peer support. Peer support can achieve this amount of impact. Beyond peer support, can we actually empower people to know how to identify signs, and how to identify maybe certain risks, and then know whom they can go to as part of that tiered care system? I think that has been how we've been trying to do it sustainably. But I think this also differs from country to country, because who can prescribe, who can provide services, who can provide medication support, I think it also depends on regulations too.
Great, like challenges, but also possibilities. Thanks, Reina. Huyan, please.
Yeah. Maybe I think we'll share three key lesson I learned from my experience. Like the first lesson is, I think maybe we have to speak the community's language and use the platform they already trust. Like many Chemsex participants in Vietnam could never come to a clinic at first, but they chat every day on Telegram, Yellow, or X. And so instead of asking them to come to us, we go to where they are. Like we talk about sleep, relationship, emotion, pleasure, sex positive, but not just drugs or risk. And when people they feel understood, they open up, and that's where we can reach out of them, and where real harm reduction begin. Even our materials reflect that. The material have to short friendly messages, downloadable self-test guide, or and small infographic people can save privately on their phone. They can bring with them. So and the second lesson is to believe in people ability to lead their own community. Like how many of our most effective peer facilitator once join as participants themselves. They know the language, they know the vibe and the unspoken rules. So when we trust them to lead the meeting of camp safe space or support new members, engagement real naturally. That's how sustainability really happen, not only through like funding, but through ownership. When people feel they belong and can contribute, they keep the model alive. And the last, I think the support must be integrated and comprehensive. I think is the keyword of APCS 2024. Yeah, people lives are not divided, so our service shouldn't be either. In practice, this means that the harm reduction, HIV services, and mental health care all need to talk to each other, or maybe may come in for HIV testing, but end up needing help manage anxiety or manage the chemsex urges. So by connecting these dots, we make care more human and less stigmas. So yeah, if I had to summarize, speak their language, trust their leadership, and connect the piece. Yeah.
Oh, very wonderful. Thanks so much, Huyan. I know we are coming over time here, and if I may, I think like because we have many people from Myanmar in this webinar, and it would not be an easy opportunity to like discuss particular contexts like these like areas with ongoing conflicts and what we have been doing in other countries. How can then it be adapted in the context with these conflicts now? So I know we have had the answers addressed a bit in the Q&A box, but would like to know if any four of you would like to touch a bit on that, like any tips, any advice on how these service delivery models can be adapted in those areas.
I'm going to say that's a tough question, so I have to think about it.
Maybe I will just do a very quick one,
Okay.
because I want to just come from that community point, because for me, my own experience around how, like in Singapore previously, there were no like chemsex or no services that were for, like people like me who's queer, LGBTQ plus, people who wanted to find support for chemsex recovery. And in these cases, where do I start? Right. I think that our starting point that led to today, which is about like maybe 9 or 10 years later, where we have the greenhouse that's running its programs as a charity, really started out as a community-led effort. There was no support group, so we started our own support group. We took resources from the internet to come up with our own manual on how we're going to run this support group. We learned from other people, and we didn't wait for governments or funders to start these things up. And I think that community building is definitely a starting point. Finding other people who are similar to you, with shared values and principles to help the community. I think that for me is really just the part that you cannot deny. Just to move forward with that together. Yeah.
And Naomi, would you like to address this as well from like that regional perspective? Naomi?
Thank you, Nitaya. Yeah, I really have nothing substantial to add, but I was moved by what Rainer said, that we don't need to wait for funding institutions to fund us in order for us to help ourselves and the communities that we are thriving in. And I was also particularly moved by what Rainer also earlier said, that the contexts are so different. For example, in Southeast Asia, for chemsex use, like it's different in Indonesia, it's different in Thailand, it's different in the Philippines. And so I think that contexts are really important. And if we want to address this issue, we have to take that in consideration, and we have to really talk with communities and involve them in the solutions, and in order to serve them better.
Wonderful. I think that's
Thanks, Nitya.
yeah, that's a very nice conclusion. And I know we have come like 6 minutes over the time schedule. But we can have a shorter break. But and we will come back at like 45. 3:45 Bangkok time here. So we'll need to conclude this session and would like to thank everyone so much. Naomi for your great facilitation, Hui An, Rainer, Fair, and Akarin. I feel that it's always great to share experience like this. And like Rainer said, don't stop thinking about what you really want to do for the community, by the communities, and then you will have like something ready to sell to any funders who will come to you one day. And it's good that now we have many funding cuts so that we can think of what we really want to do in our free will instead of like following what the funder will tell us to do. So think of it as an opportunity. Thank you so much, everyone, and we'll come back 8 minutes after this. Thank you so much.
has to be with the community.
at the IIS, it's what we do. We convene people because only when science, activism, and policy all come together do we make a difference.
Every effort that we do has to be with the community.
At the IIS, it's what we do. We convene people because only when science, activism, and policy all come together do we make a difference.
Let me welcome you all back to the last session of the IS Educational Fund virtual webinar for focusing on Southeast Asia. Sorry, I forgot to put on my glasses. So let me now introduce you to our next speaker, Purvi Shah, who is the regional advisor at WHO Zero. Purvi will be presenting on digital health and virtual interventions for HIV in Southeast Asia. And Purvi, you have 10 minutes here. The floor is yours.
Thank you so much, Nitya, for the introduction. I'll be switching off my camera to save bandwidth, and I'll switch it on again later. So, Is my screen visible? Can somebody just confirm?
Yes, we can see it. Not yet in full screen though.
Now?
Yes, now it's perfect. Thank you.
Okay, thank you. So good afternoon, everyone. And today I'm going to be presenting on digital health and virtual interventions for HIV in Southeast Asia. Just to give everyone a little background, a few years ago when we were implementing one of the flagship programs, one of the flagship HIV programs, we actually were not finding people in the physical spaces. And that's when we realized that a lot of people, especially key populations and youth, have started moving to virtual platforms to find friends, clients, and sexual partners. And this population actually, did not really identify themselves as key populations. They wanted to be fluid. They did not want to be categorized as any of the four key populations that we normally refer to. And therefore, they were never really they had never really accessed any services through the usual national programs. Most countries had started exploring these virtual platforms to reach these people, but there was no structure that was attached to it. They would just reach out to people, but would not be able to follow up with them for access to services. And then COVID-19 actually brought about a boost for mitigating impact on programs. And that actually gave a boost to virtual interventions as to actually providing virtual services. So we also tried to assess as to why were populations not accessing physical services, and we found many reasons. These are some of them. Lack of information, of course. They were non-identifying populations, like I mentioned. They were not identifying themselves as key populations. They perceived themselves to not have any risk behavior. There was a lot of stigma discrimination attached to physical spaces. There was lack of options in terms of accessing services, and there was lack of confidentiality as well. And so when we explored, virtual options of providing services, we saw that there was a great potential in terms of the technology and the internet that was available to people in these times. So if you see some of the statistics that I've put up here, 5.56 billion people have access to internet, are active internet users, of which about 5.24 billion are active social media users. So they use social media platforms for various reasons. And about 6.5 hours is being spent on the internet for various reasons. If we see here, this map clearly shows us that about 61% of the population in Southeast Asia are social media users. This statistic actually shows us that digital has a role in taking healthcare choices. If you see, there has been a steady increase, or at least it has been stagnant in terms of the percentage of people that use the internet to, inform them on healthcare choices. 122 million people actually have tried online doctor consultation services. 1.3 billion people are actually using some form of digital health treatment and care. Either it is an app or a platform to book appointments or to access services or for doctor consultations. But so many people are currently using digital health treatment and care applications or some form of technology. And if you see, there is a varied age group as well, who have access to internet, and they are using the internet to check healthcare information as well. So, I mean, even today, if we have a question, we obviously immediately go to Google, or now with ChatGPT or any other AI platform, it's become even more easy to just get something on healthcare information quick and easy. So there are various types of digital interventions that are available, and it is important that we understand what digital healthcare includes. So it could include telemedicine, include just simple electronic health records, moving from paper-based records to digital health records, any form of mobile health. So whether you are doing a doctor consultation or booking an appointment or ordering a self-test kit online, to patient monitoring done by the healthcare providers, and of course artificial intelligence now that we see is giving a boost to the whole digital healthcare arena. Also, digital health is unique in many ways because it is beneficial to each level of beneficiaries. For example, it is beneficial to the patient, or it can be used by the patient, it can be used by the professional or the healthcare providers, as well as by the organization that are implementing these programs. So for various things that you see in this circle, digital health can be used as multiple levels, has multiple stakeholder benefits. It could have shared vision and outcomes. It's real time. It helps us to be more accurate and, of course, time saving. Just wanted to give some examples on what sort of digital health interventions have been tried out. And this is an example of density mapping that was done a few years ago in Mumbai, India. This was done using the Grindr app, which is a gay dating app. We wanted to actually see the density of people that we could find for outreach in certain areas of this city. And so outreach workers were given this data, and they were able to then log into Grindr and sort of provide outreach services to people during those times of the day when they were most active. This is a video of a social media influencer from Indonesia called the Catwomanizer, who's then showing her followers how quick and easy it is to use a mobile app to book an appointment for an HIV test. So, at times when we don't trust technology too much, I think influencers can be very useful to us to spread the word and remove any myths or misconceptions that people might have with regards to technology. This is an example of a social network-based approach, or index testing, as we might also know. So here we did it, any kind of snowballing that we do in research, we use physical coupons. Here we used QR-based e-coupons, where we went into hidden networks, hidden MSM networks, and we found a lot of people who were never tested, a lot of people who had partners who are positive as well. And so through this exercise, this was like a pilot thing that we did with a very small population. But what we found was a high positivity among this new group of people that we found. So about 3.3% of HIV positive and 10.5% of syphilis positive individuals. And these are absolutely new, never tested populations. These are not networks of known people. Digital interventions could also be used for social media demand creation. So any posts or any engagement with people online using social media or dating apps or any of the virtual platforms could actually help you create demand for your services, and what kind of services are virtually available for people to access. These are also some advertising examples, advertisements on Instagram, on Google search engine optimization, or even dating apps like Grindr can actually help people to get that information on, what kind of services are available virtually and where can they access them. This is an example of a self-testing or, virtual intervention implementation where you order a self-test kit online, you get it delivered through a food delivery app. So Grab, if you all know, in Southeast Asia is a well-known food delivery app, and this particular organization actually partnered with Grab to distribute or deliver their commodities to populations that ordered self-test kits or PrEP also online through their website. As good and as rosy and as nice that virtual interventions or any form of digital technology would sound, it has its fair challenges and considerations, and it is very important that we take care of these. So data privacy and security equity is extremely important. We cannot have this sort of a model available for some people in a country and not to other people in the country. It's important that whatever model we plan or whatever intervention we plan is based on evidence. Is extremely important that we understand what works and what doesn't work with the population that we're trying to reach. And there is a lot of resistance from stakeholders, which we need to advocate towards, which we need to try and explain them in terms of the benefits that technology would have for reaching out to more and more populations. So it's extremely important to protect safety and security online, informed consent, secure access to data, especially our population, because we are already dealing with vulnerable and marginalized populations, and it is extremely important to sort of secure the data that we store on our devices while we are providing services to them virtually. There are a lot of products that are available by WHO on digital health. So we launched the virtual interventions policy brief in 2022. Thereafter, launching a budgeting guide helping countries to budget virtual interventions for their grants or grant cycles that may be upcoming. There are a lot of recommendations on how to use digital health interventions for health system strengthening. And now with AI coming into the picture, we also have a guide on ethics and governance for AI for health. And there are many, many more products. I mean, I've not laid them out all here, but I think that, if you go to the WHO website and type digital health, there are various products that are available that can help you plan your digital interventions as well. So I would like to end here and happy to take any questions. Over to you, Nitaya. Thank you.
Thank you very much, Purvi. I think that's a great overview of how we look at virtual solutions, digital interventions, and we will keep the Q&A until the end after we have learned from the other two countries, Thailand and the Philippines, on their virtual solutions. So please let me now introduce you to our next two speakers. Our first speaker is Lord Art Lomarda, who is the program manager at AppCom in the Philippines, and Kritapon Termwanit, who is the communications and marketing manager, and Pripta Tangerine Clinic operations manager at IHRI in Thailand. Both of them are going to present to us the Beyond the Clinic virtual solutions for HIV and sexual health services from their respective country experience. So LA, you may start sharing with us the Philippines experience.
Hi, everyone. For this, can you see my presentation?
Yes, we can see your presentation, but not your video.
Oh. Hi, everyone. Hi there.
Hi.
Just a note, hi. Just a note, I'll turn off my camera to focus on the slides. I'll be turning on my camera for the Q&A later. Thank you. Hi, good morning and good afternoon, everyone. I'm Lord Art Lumarda, Program Manager for Love Yourself in the Philippines, a community-based organization that provides free and inclusive HIV services across the country. Today, I'll be sharing how we've taken HIV sexual health services beyond the clinic using virtual platforms to reach people, wherever they are, from our islands to the Filipinos abroad. The Philippines continues to face one of the fastest growing HIV epidemics in Asia, with around 55 new infections every day, most among young Filipinos. But the country's geography makes access a challenge. With over 7,000 islands, reaching clinic isn't easy, especially for people living in the provinces. Many clients live hours away from testing centers, and there's shortages of healthcare workers in most regions. Even when services are free, transportation costs or loss of income can stop people from getting tested. And perhaps, most importantly, stigma and discrimination still silence many. People fear being judged or outed, so they stay away from clinics. These barriers, distance, workforce shortages, money, and stigma show why we needed to reimagine HIV care. Through virtual solutions, we're now bridging services closer to people no matter where they are in the Philippines. At Love Yourself, we realized that no single platform can meet everyone's needs. So we built an ecosystem of virtual clinics that complement each other. The Embrace Virtual Hub served as our nationwide entry point, offering HIV testing, PrEP, and sexual health consultations for free. In Visayas and Mindanao region, Amping Virtual Hub extends the same services to areas with fewer brick-and-mortar clinics. For Filipinos abroad, Embrace Kabayan connects overseas Filipino workers to virtual consultations and follow-up care, often in coordination with the Overseas Workers Welfare Administration Office. Meanwhile, Embrace Plus, our mental health hotline, provides call-based psychological first aid and emotional support because HIV care doesn't stop at physical health. And finally, X by Love Yourself caters to the general public with paid self-testing and telehealth services treatment, helping sustain the operations. Together, these platforms form a status-neutral digital ecosystem, bridging distance, stigma, and costs that HIV care can truly reach anyone, anywhere. Our virtual model simplifies how Filipino access HIV prevention and treatment, combining digital systems with human support. For HIV, we provide free self-test kits that can be booked directly through Facebook Messenger, guided by our Embrace chatbot. Clients only pay for the delivery fee, while our integrated e-commerce and courier system ensures orders are packed, shipped, and delivered quickly and discreetly anywhere in the Philippines. The same process supports PrEP services. Clients complete online screening, get their prescription digitally, and receive their free medications via courier. For consultations, doctors and nurses meet clients virtually via Google Meet, Viber, or EMR-linked teleconsults, ensuring privacy and proper documentation. Throughout it all, trained telehealth associates and peer counselors provide real-time guidance, making sure digital experience remains human, confidential, and client-centered. In its early months, Embrace Virtual Hub has already shown how virtual care can expand HIV access nationwide. From April to June 2025, we received over 4,400 testing and general inquiries, with 1 in 3 clients proceeding to testing. Among those who reported results, 12 very active and all linked to treatment, either within Love Yourself hubs or through partner clinics. 89 clients started PrEP, reflecting growing trust in digital HIV prevention. What's even more encouraging is that nearly half, or 49%, were first-time HIV test takers, showing that virtual access reaches people who have never tested before. And importantly, 73% of HIV self-test kit orders came from outside Metro Manila, showing that digital platform can bridge the gap for people living in areas with limited HIV services. These early figures are just from the first few months of Embrace's rollout, and as we progress, we have more data and impact and continue to grow. While virtual HIV services have made testing consultations more accessible, they also come with real challenges. Connectivity issues often disrupt sessions, and many clients, especially in provincial areas, struggle because not everyone is familiar with technology or comfortable using chatbots and online forms. In some provinces, fast and stable internet connection is still unreliable, making it harder for clients to finish consultations or submit results. Our telehealth team also handles a large volume of messages daily, which can lead to fatigue, especially when combined with limited human resources. Finally, the supply of HIV self-test kits remain dependent on government stocks, so availability can be unpredictable. These challenges reminds us that digital HIV care is still evolving, and we must keep bridging the gap between technology, access, and people. So what's next for our virtual hubs? We're expanding coverage to Amping in Visayas and Mindanao, Kabayan in areas with overseas workers welfare administration offices abroad, Embrace Plus soon to offer chat-based mental health support, better integration with PhilHealth, the National Health Insurance Program, that will ensure the clients are properly counted and cared for within the country's health system. We'll also broaden services to include reproductive health, hormone therapy, and mental wellness, recognizing that sexual health goes beyond HIV. And by strengthening automation, we can let technology handle routine processes so our team can focus on what matters the most: real human conversations with clients. The goal is simple: better adherence, stronger retention, and more satisfied clients across every virtual hub. Virtual solutions are not here to replace traditional clinics, but to extend compassion and access to those who need it most. As we move forward, our mission will remain the same: to make HIV care more accessible, inclusive, human, both online and beyond the clinic, embracing health. Thank you.
Thank you so much, LA. For some reason, I couldn't turn on my video, but that's okay. Thank you so much, LA. And I'm so sorry that I introduced you as being with AFCOM. It's love yourself.
Okay, it's
Always love
okay.
yourself.
We used to have partner with AdCom, so it's okay.
Yes, we are all like a same family. Okay. So thank you so much, LA. And I think that touched on key issues for consideration when we want to think about integrating virtual solutions as part of the overall program and not replacing, as you mentioned. And I think that repeats the theme from yesterday, that people need options, and it's just not like one option replacing another option. So thank you so much. And now let's move to Gritapon Termwanit Kung, who will then share her experience from Thailand. Kung, please.
Thank you, Dr. Nitya. Hi, everyone. It's my pleasure to share with you the experience from Thailand going beyond clinic using virtual solutions to expand access to HIV and sexual health services. Yeah, so for many people, traditional clinic settings are not always the most accessible or comfortable. As we know, there are many barriers that stop people from seeking care, such as stigma, distance, or concern about their confidentiality. And going beyond the clinic, like Dr. Nia just said earlier, it doesn't mean replacing it, but it means giving people choices, options, and empowering them to manage health, their own health, whether it's self-testing, telehealth, or in-person visits. Clients should be in control of how, when, and where they receive services. So at IHRI, we established Prita Tangerine Clinic in 2020, but many of you probably have heard more of Tangerine, which is the first transgender-specific health center in Thailand, founded in 2015. So it's going to be 10 years old this November. So our goal was to be one-stop clinic to provide fast, stigma-free client center and easy-to-access services supported by our in-house laboratory, and also integrated care, including sexual health, mental health, gender-affirming care, substance use harm reduction, and telehealth. The telehealth service at the clinic, we provide HIV self-testing with linkage to prevention like PrEP or PEP, as well as PrEP follow-up, STI self-collections, ARV purchase, and also self-abortion services using medication. The idea is to offer continuity of care. A client might start virtually and then connect to in-clinic services whenever needed. Or the journey can begin in the clinic, for example, with the first consultation or lab test, and then continue online for follow-up. In fact, the telehealth service can be integrated at any point along the care pathway, giving people flexibility to move between online and in-person services as it suits them. Our service are provided, the platform that we use is Line Messenger, which is the most widely used communication app in Thailand. And people already use Line every day in their personal and professional lives. So we didn't want to create a new platform that would require extra effort to adopt. Since we launched the telehealth services in 2022, we have served over 5,100 clients with more than 10,600 service transactions. What's important here is the diversity of services that people are using. You can see here that more than 1,500 clients access HIV self-testing. Over 500 clients receive PrEP, and this includes people who had their lab result done elsewhere but choose to receive PrEP with us. And 40 people access PEP, and around 650 people purchase ARVs. Also, 81 clients use STI self-collection kits, and more than 2,300 clients access safe abortion services. So our telehealth flow for HIV service reflects a status-neutral approach, meaning that regardless of a person's HIV test result, they are supported and linked to prevention and treatment service without stigma or judgment. If someone tests HIV negative, they will be connected to PrEP to prevention like PrEP or PEP or condoms or even STI services. If someone tests HIV positive, they are linked quickly to confirmatory testing, treatment and retention in care. So in both pathways, the goal is the same, is to keep people engaged in health services and reduce HIV transmission. And this is also like a hybrid model because some step, like I said, it can happen online, such as teleconsultations and risk assessments, while others like confirmatory testing or treatment initiation still require in-person care. So this hybrid model allows us to combine the convenience of virtual with the assurance of clinic-based services. And the key is integration and flexibility so that people don't get lost in the process. So between May 2022 until August this year, we distributed about 1,900 HIV self-test kits to over 1,500 clients. Of those, about 43% of clients reported back the result, and the vast majority were non-reactive. And among those who tested reactive, 22 HIV positive cases are linked to ART, and that's 100% linkage to treatment. On the prevention side, 219 clients, which is about 35%, receive PrEP services, including new initiations, refills, and restart, and 40 people receive PEP. For PEP service on telehealth platform, we just started this year, so the number is still low, but we receive a lot of interest from the clients. So overall, the data shows that telehealth doesn't just distribute HIV self-test kits, it actively links clients to prevention and treatment services. So the telehealth app PrEP Tangerine isn't limited to just HIV prevention and treatment. We also expanded to include STI self-collections where clients can collect samples at home and send them back to us, as well as safe abortion services. On the left, you can see our STI self-collection service. 81 clients order self-sampling kits, and 17.3% were found to have chlamydia or gonorrhea. And almost 86% of them with the reactive result received treatment. On the right, our safe abortion service has reached over 2,300 clients, and more than 600 of these also received HIV self-testing. 45 reported non-reactive results, and 7 went on to start PrEP. So this shows that even when people come to us for one health need, which in this case, for example, abortion service, they often have other health needs as well. So telehealth kind of enables us to integrate HIV testing, STI management, and even reproductive health into one continuum of care. This way, clients don't have to navigate fragmented systems. They have one trusted entry point for comprehensive care. Of course, there are challenges. We need to make sure of quality assurance that services delivered virtually are still clinically accurate and safe for clients. And also there's still the issues of financing. Right now, not all virtual services are covered under Thailand National Health Program, and that really kind of limits how far we can scale and sustain the services. And lastly, not everyone has the devices, internet, or digital literacy to access telehealth, but for those who do, it's already proving to be a valuable option. So looking ahead, we are developing empathetic AI-powered chatbots to provide counseling and help clients navigate services. And this is also to reduce telehealth workload so that we can pay attention to those who really need human-to-human services, just like Love Yourself did as well. And we also envision comprehensive digital service platform that integrate not just sexual health, but also substance use harm reduction, mental health, and even legal and work support. And the Thai government is now exploring how to take these integrated digital platforms to the national level, bringing all these multiple services together into one unified, sustainable model. So to conclude, virtual solutions are not a replacement for in-person care again. They are an expansion of possibilities. So by combining clinic-based and virtual services, hybrid models give people choices and empower them to manage their own health. And this way we can meet them where they are while ensuring quality and inclusivity at scale. Thank you very much.
Thank you so much, Gung. That was a great presentation, and it's great to see like the services that we have started a few years ago turns to like data. So because we always need data if we want to move forward with policy advocacy. And now can I ask Purvi LA to come back to the floor so that we can open the Q&A session. Thank you so much. Please feel free to send your questions into the Q&A box so that we can like prioritize the questions to be asked here. So now, let me start with the first question, because I think I am very impressed with what LA and Gung mentioned about kind of the integration of like these virtual services into the national health system. LA mentioned about the integration into the field health. Gung mentioned about the National Health Security Office. So I just wonder what has been kind of like the steps that you have taken into like getting the national health system being interested in virtual solutions, and what do they need to like kind of consider including this into the national health systems, and are you being reimbursed by providing virtual services to your clients? Maybe LA, you can start first.
Hi there. Yeah. That's a good question. Actually, we're just starting to integrate the PhilHealth and the virtual clinic that we have right now. It's actually a new program with the government under PhilHealth. It's called YAKAP. YAKAP in English is Embrace. That's why that's the name of our virtual clinic, Embrace YAKAP. We're actually just started onboarding it in our facility, in our virtual facility too. So our land-based facility and also a virtual clinic. So it's much up in the air, but it's around $20 support from the government for every Filipino who has PhilHealth. Just technically everyone should have. And then this goes to their primary healthcare. So basically, it's more prevention type thing that we can access and hopefully provide consultations and diagnostic services to our clients, hopefully. In the facility base, it would be much easier to do that because everything is in the facility. They have clinics, they have diagnostic labs. However, with us, with the virtual clinics, it's still up in the air and how we can access those funds specifically, but we can provide diagnostics outside as a third party. And then for the consultation, we can provide it virtually. And the rest, I think, would fall back on the facility that our Love Yourself clinics helps. Thanks.
Yeah. May I have like one follow-up question, because before I go to Gung, because like what we have learned in Thailand is that you usually will have to have the health issues being listed as eligible for virtual health service to be delivered. So for example, in Thailand, HIV or any STIs have not yet been listed as like a health condition which can which can have like health services delivered through virtual consultation. Same to like safe abortion, medical abortion here. It's not yet listed, but like people are doing it, and like when then we will have to like demonstrate the uptake, the effectiveness, the safety of these services in order to get like policy endorsement on service reimbursement. How has this been going on in the Philippines?
Hi. Actually, we're just starting with, as mentioned before, we're just starting with Yakap. Most I've seen are mostly types that are pre-diagnostic for cancers if they have, and some other sexual health services, sexual health diagnostics I think are covered too. But most are like general consultations specifically to address the primary health of the clients here in the Philippines. And hopefully we can onboard other stuff with that. One thing that's also good with the AHAP, the PhilHealth program, is that they have this medication, free medication. So other than the $20 I've mentioned before, they have, I think, around $100 or $200 of, wait, sorry, of medication that is free. But those are for like the basic ones for diabetes, for high blood pressure, but those are not yet currently in the, what do you call this, in the system right now with us with ourselves. We're still trying to onboard with that for our pharmacy. But I think we can access already that with other facility or clinics here in the Philippines. But as I said before, the Yaka program was just onboarded like last quarter, if I'm not mistaken. So everyone is like starting to catch up on how they would integrate that in their virtual clinics or even in their hospitals or clinics too.
Okay, thank you so much, LA. That's very clear, and we hope to like learn more from you in the next few months. So, Kung, would you like to comment on your thoughts on this?
Yeah, I mean, for Thailand, we are lucky that the government allowed us to reimburse HIV self-test. So it's free for all Thais, and we can adopt that to our telehealth services. However, we realized that the method or the platform that the government is using is not designed for telehealth from the very beginning. It was designed for clients to pick it up at the hospital or healthcare facilities, which is probably not a good option for those who don't want to go to the facility itself. So I think many providers here have been creative in integrating it into telehealth services. However, even though that is free and covered by the country, by the government, linkage to prevention is not. So all this data that we are presenting today has been submitted to the government, and we will have to produce more in order to advocate for them to accept PrEP telehealth services into the country, I think, because otherwise, I mean, since we cannot dispense PrEP for free, because if you come to the clinic in person, you can get it for free, but not on telehealth. So we need proof to see that HIV self-testing can be linked to PrEP for sure, and even to start and to follow up in many processing, and you're not gonna lose anyone. So this, I would say that the step that we are with the government now is to show that data to them, and also I know that they already open up for the platform and thinking about the reimbursement costs along the cascade. And that's the step that we are at, I think. But in the future, the National Health Security Office also interested to have this platform scale up nationwide. So they still need data that we can use the telehealth platform to provide all the services, not just HIV, but also harm reduction, mental health, and legal and rights. So like, comprehensive care. So that's going to be challenging because it's going to go through a lot of piloting processing before we can present them the data. But I think at least they have that interest in scaling up.
Yes, thank you. I think that's a great summary of like what will still like be steps that we need to take until like we achieve what we really want to see. And it's always fun that it's not too easy to say that, okay, we can just reimburse a virtual health service from our national program. And Purvi, do you want to comment on like the what is the status in India? And I will also have a follow-up question in terms of like as WHO, what do you think about this?
Nita, in India, we have various forms of virtual interventions that have been piloted, tested. It was also integrated into the national program for a few components of the virtual interventions. But issue is sustainability. So where do we sustain this program from? And I think most countries in the region and even in Africa that we've seen have this issue. They do start with platforms with foreign funded donors, etc. But then when it comes to sustaining the services or making it equitable or making it affordable, I think that's where most countries are falling behind. And that is what we need to plan before we initiate any such model of virtual intervention. So that's where we are. And I think as WHO, what we have been suggesting to countries is it is important to assess the gaps of the population that you want to reach with virtual interventions. It's not just that it's trending and that is why you make use of a device and start reaching out people on virtual platforms. It's important that you understand the need of the population, the need of the community, and are basically building a program that will help them access services with their needs and preferences, with in regards to their context or with regards to the challenges or the barriers that they have been facing. I think that way we can make the virtual interventions program a success, because then we are providing additional options to populations to access services. Whatever exists in the physical world is obviously there and it's great. What we are trying to do now with the whole virtual world or the telehealth component is to bring in people who would otherwise not come to physical spaces for services. And that is why it is important that we plan with them and we plan for them. And I think that is what WHO has been saying in all their policy documents as well as all guidelines as well. But at the same time, I think WHO is also, has been very cautious, has included a section on, responsible use of technology in every guideline. If we see the guidelines, it's important that we understand the challenges, the barriers, or the technology related security risks, and it is important that we plan our intervention around that. So that we're taking care of all that and not putting our population in further risk. Thank you.
Yeah, thank you so much, Purvi. I think that's very clear that if you need like any endorsement from WHO, there are so many tools that you can use to advocate in your country with your policymakers, right? And I think that partially answered the question that was put in the Q&A box regarding the policy commitment to invest digital interventions tailored to meet the needs of clients in conflict areas, and I think that's something that I think it's not easy, especially when we are now facing funding cuts, and like many people prioritize different things, and it's always hard to kind of like advocate for your issue. The other question here is is there a particular training program available for telehealth which can be administered by community? I think that's a great question. And I also would like to add to this question, I mean, in a bit more detail as well, because like we know that for us, HIV self-testing and PrEP initiation and PrEP follow-up, like these are questions and there are resistance everywhere that okay, it's probably okay for you to use HIV self-testing for a PrEP follow-up, but not for initiation. But I think it's very crucial that WHO says this repeatedly and very clearly that HIV self-testing can be used for PrEP initiation. So that's one step. And now we're talking about HIV self-testing by telehealth with PrEP initiation and with PrEP follow-up. Can you point us to like any part of WHO guidelines that we can use to kind of like shortcut what we need to demonstrate to our policymakers?
Thanks, Nitya. I think it's extremely important, and WHO in their new revised consolidated testing guidelines that were released in 2024 have made it very clear that self-testing can be used for all types of PrEP and for initiation as well as continuation of PrEP. That includes the new injectable PrEP as well. And this has been repeatedly, I think announced in various forums, platforms, and of course the guidelines has more details as well. Now, the policy brief that we developed on virtual interventions talks about all the approaches that have been tried on virtual interventions, which includes self-testing as well. So that is one document that you can definitely refer to. There are other guidelines, as I showed in my slides, that have been developed for specifically for use of virtual interventions by WHO, recommendations on how to use and where to use and how do you advocate for the use, etc. All of that is included in that document as well. So I think there are various ways of doing this. Of course, WHO documents can add to it, but I think the most important lesson that we have learned while advocating for virtual interventions is the voice of the community. If we have the community with us, if that is what the community wants, I think that is the best way to advocate. And we've always seen a sort of a success route when we've actually voiced the community needs and preferences. Various countries that I have sort of supported over the last 10, 12 years, this is what we've seen. I mean, the minute you start talking about okay, the community can't go to a physical service center because of time, because of discrimination or whatever. And that is why we want to give them telehealth. We want to make sure that commodities reach them to their home. That is where the stakeholders understand how we'll be able to get more people into services. That's what has worked the most. Of course, evidence, of course, research, of course, WHO products would be like an added advantage. But I would suggest the community path, taking the community along in building the interventions as well as for advocating.
Mm-hmm. That's very useful, and I think like many countries are also doing community-led monitoring, and I think that's could be like the quantitative component of how you can share community voices. So the question in the Q&A box is particularly around training program. So any of you, our three speakers here, do you have any your own training program, curriculum that you would like to share, or you can share with the audience here?
For us, there's no training program that we specifically did based on the telehealth, but probably the COVID-19 pandemic was the training program that gave us the telehealth. And here in the Philippines, it's actually covered by our two laws in the Philippines. One is the Medical Act and the Data Privacy Act that allowed us to do telehealth in the Philippines. Other than that, we're just using the WHO guidelines too and the laws here in the Philippines.
Same here. I think we don't have any written curriculum or a training program really for telehealth. But I think every organization sort of trains their outreach workers for virtual outreach, and how do you reach out to people? What do you do? How do you connect them to services? What are the things that you need to take care of? They train them on how to communicate with people online because it's a little different from offline. So those are things that are definitely happening locally within CSOs, CBOs, and maybe international NGOs as well. But I haven't seen a written curriculum or a training module or a program specific to telehealth.
Yeah, likewise, I don't think we have the actual training program. The clinic has a SOP for telehealth service for sure, but we don't have a training program as in a curriculum. But that's quite interesting to see if we can actually do that. However, I still think that telehealth in different countries it varies. So because the digital divide varies in different countries, the conflict, the censorship, surveillance, so many others contexts that need to be considered to adapt the program.
Yes, I think that's a very good question that point us to what will be needed, like in addition to all the guidelines that we usually use guidelines to advocate for changes, but we do need capacity building tools and to make sure that we are doing this safely, do it as effectively as we can. So yes, I think that will be something that we will work on and we'll see if we can like share any of these with you all. Oh, okay. So we have we may have time for like another quick question here. And monitoring and data coverage from the virtual platform. It's probably challenging. How this can be improved, or do they have a monitoring tool to gather data? Yes, we are doing this. We're collecting data. What are like kind of is there any standard monitoring tool, standard data collection that we can use? I guess probably to ensure safety, ensure quality, as well as to use for like as evidence-based advocacy. Any of your program using this tool?
HIS2 has been found to be really good in terms of data management, as well as coming up with reports and analysis and evidence building, etc. I think that is being used by a lot of countries and programs. Also, countries that have, organizations that have developed their own virtual platforms, like I know FHI 360 has their own, it's called QuickRes. So QuickRes has a very, very robust backend which captures data. It allows the healthcare providers to track track the journey of the client, as well as then give you monthly reports, analysis of what are the trends, where is the follow-up required, how many dropouts, or whatever you want to see. I think that has the capacity to do all of it. So it depends really on what is the need, whether it's like a country-based data analysis that you're looking at, or it's like a more program-driven or project-driven analysis. I think the platform will differ based on that, based on the need of what exactly do you want as an outcome. But I have seen great examples and great data analysis that is possible through the online platforms with the data collection that we do through client-facing platforms like QuickRes, and also DHIS2, where data is fed and then analyzed. So both ways, I think it really works well to have good analysis and accurate, evidence and analysis.
Thank you so much, Purvi. I think that would be a good start for us all to think about the application. Gung and LA, do you have any like final message to say before I end this session?
Hi, thank you so much. Final messages, let's give more hope to telehealth because it's very, very important, especially for the people who are in the far-flung areas to receiving the care and the support that they need, especially they are the most who needed this most. Thank you.
Yeah, I think, you know, to scale this up, we have to simplify the service and use a client as a center, not the health issues anymore. And I would like the government to understand that, you know, everything can be done. Like the guideline already proves and everything. So we should be able to move this forward quickly in order to expand the service to those that we haven't reached. And that, I think that will be an impact to the global health in general. Thank you.
Thank you so much. And so I think we have come to the conclusion of this session. And I would like to thank Purvi, Gung, and LA once again for this very powerful session. And I hope to learn more from you all next time. And so now I would like to just make a very final words here that we would like to thank the IAS Educational Fund team for making this virtual symposium possible, focusing on Southeast Asia. We would like to thank all the speakers, panelists, facilitators from yesterday and for today. We have learned a lot. And also would like to thank our sponsor, Weave Healthcare and Gilead Sciences. And I would like to just end by repeating what Huayan, one of our panelists today, just mentioned, that we need to trust in the people, trust in the community, and trust in community leadership so that we can bring innovations, can integrate services in a very empathetic way so that we bring health equity to as many people as possible. And I would like to thank all the audience very much and hope to see you again soon.